Okay, so do you feel like this treatment, intralipid infusions, IVIG, prednisone, all those different treatments that are in your toolkit, do you feel like those are for everybody or for just depending on severity? How do you differentiate?
Well, it depends on the severity of the problem. I generally start with probably depending on the abnormalities that we detect, because, by the time they're getting treated, we're going to do a full immune panel, which will include natural killer cell levels, natural killer cell activity, because sometimes the natural killer cell levels may be normal, but the activity may be elevated. We look at the phospholipid antibodies, which are antibodies involved in attacking the vasculature of the developing placenta that could be coexisting that the patient is not aware of. Or sometimes the patient has a history of something like that already. I just saw a patient last week who had a history of spontaneous strokes in her early
Wow.
30s. She had
Mhm.
2 strokes and was found to have what's called a cardiolipin antibody, or actually 2
Mhm.
antibodies in that panel. Now she's on blood thinners. So we already know ahead of time that that pregnancy is going to be much higher risk, or somebody like that who's really severe, we probably shouldn't have her carry a pregnancy because the risk of stroke may be higher. But again,
Mhm.
depending on the patient, will determine what kind of medications we might use. So, in some cases, we'll use blood thinners where the phospholipid antibodies are positive, but they haven't had any serious complications yet. But we think that we want to avoid something like that. So we'll use blood thinners and prednisone in those patients. And we may add intralipids too, depending on their natural killer cell situation. And then
Okay.
obviously, if those things are not potent enough, we may add other things like IVIG, which is the old standby, which is actually the strongest treatment we have. But that again is not for everybody. It's very, very expensive. It's not covered
Expensive,
by
right?
the insurance, and they may need multiple treatments, to get you through the first trimester. Now, there are some
And
newer
why?
things
Mhm.
that we're
Well, I was
actually
just
adding now.
wondering, why is it not covered by insurance when it works so well? I've heard like such good results from
The
IVIG,
FDA doesn't
Yeah.
cover it. They still consider it an investigational
Okay.
tool for something like this. So the data is mixed in terms of whether immunologic abnormalities really are causing some of these miscarriages or whether it's still the embryo. Even though we know, and from our experience over the years, we think IVIG and those treatments are a very potent part of our armamentarium. So
Mhm.
we do think that, and not all the doctors do, and that's why the FDA hasn't done enough studies on it to show the beneficial effect. But now, even off label, now we're using anti rejection drugs a lot, like Tacrolimus, which is used in, transplant medicine, particularly for kidney transplants, things like that. We're using lower doses than they use, but
Mhm.
there shows a lot of promise in reducing the immune activity that goes on to help prevent actually implantation failure. So somebody with implantation failure, we may resort to using tacrolimus and various combinations with other medications to help retard that problem in terms of success rates. And, in various countries, particularly Japan, they're using it quite a bit with a lot of
The
success already.
Tacrolimus is very interesting. And there's a question like, is that safe during pregnancy? Since transplant patients are told to be careful with certain medications, when they're using those
Well, it is safe.
anti-rejection medications. Yeah.
We don't use the levels of the drugs that they
Mhm.
use. They use 15 milligrams. I don't go over 3 or 4 milligrams for that drug, but
Yeah.
it's been determined to be safe in pregnancy, so there's no real issues.
Okay.
Although we try to taper it off by the
Mhm.
end of the first trimester, particularly because most of these people are using it for implantation failure,
And
not recurrent pregnancy loss necessarily.
if with our patients, we had a patient today actually who we've been working with acupuncture during her IVF, who's on the full immune protocol as well with tacrolimus and prednisone, and she's been through several IVFs that did not work. She is pregnant. She found out today, and her levels look higher than they've ever looked as far as her HCG. And for she's also on blood thinners as well. So for that patient, we support them as far as on our role doing acupuncture to help with immune modulation. We're not interfering with the medications, but we can. There are some studies about acupuncture and natural killer cells where it actually can kind of help them stabilize if they're too high or help them if they're too low. So it's kind of a balance with homeostasis that we try to achieve, and also with blood flow, with stress relief. As we know, stress negatively impacts the immune system in many ways. So we are working with our patients and seeing their progress and seeing how these new treatments are actually benefiting them. And I think it's tremendous that we have all these tools now that were not there when we were practicing like 15, 20 years ago with these patients. Like the only solution that I remember them being told was just, blood thinners or baby aspirin or just keep
Right.
trying. And we had patients with the 8, 9 miscarriages sometimes. And it was just heartbreaking. So I'm glad that there are resources now and there's different protocols out there that are helping these patients. And what do you see as far as your patients, as far as the success rates with these types of treatments in your clinic?
Well, again, depending on the problem, determine the success rate, depending on the age of the patient, the quality of the embryo. All those things probably have to be taken into account. But,
Mhm,
we know, I think from experience over the years, that depending on what we do, especially in these difficult cases, some of them we may not be successful. Some of them are so difficult that we just cannot have a success. And we determine, listen, that the best course of action may be surrogacy in certain cases, rare cases, but that happens. But,
mhm,
once we get up into the more difficult cases, sometimes we even have to resort to the fact that, hey, maybe it is the egg quality. Maybe it is part of it. So some of these people are using donors and still using immune therapy. So that's still potential possibility for certain patients. But
mhm.
in the majority of them, they do well, especially if they're getting into the more stronger treatments, such as IVIG. They generally do very, very well because it really works. There's an article that was published a couple of years ago, I think, in the South Asian literature, and it just was titled IVIG, It Works. And
That's it is. Mhm,
they never really went into the in depth how it works because nobody knows for sure how it works,
mhm.
but we have an idea how it works. But it's a very, very successfully used medication, especially over there in Asia.
If you were talking to a fifth grader, could you explain what your theory is of how these medications are working to help the immune system and to stabilize or to help prevent a miscarriage?
Well, I think, because the immune system is involved in participating in helping the embryo implant. And there are
Mhm,
certain pathologic situations where the immune system isn't getting the proper signal for either assistance, or it's not getting the signal to restrain from becoming overbearing in
mhm,
terms of what it might be doing to the embryo, where the embryo is getting, well, attacked by chemicals that shouldn't be there. And the embryo has an unfavorable environment because of some of these chemicals that, are secreted by the immune cells, and then the embryo can't attach. So our job is to figure out, what's going on with the immune system, what's going awry there, and potentially try to block those chemicals from being activated and forcing the embryo from, non-implantation.
And does it act like a decoy sometimes as far as like because the embryo is half foreign, half self, sort of,
Well,
or it's
exactly.
basically working on the
The
inflammation?
immune system has to recognize the embryo.
Mhm,
That's part of the woman's body, but the other half is foreign from the husband or partner. And that's where the immune system has to develop a type of tolerance for that. And that's where the system becomes, goes awry. And that's the situation where now the immune system starts to attack instead of protecting it. So that's where we have to intervene with certain medications, such as Tacrolimus or Prednisone or IVIG, whatever it may be. So that's where, we think that those things really can affect the success rates. And we've had numerous cases where it's helped over the years. We
mhm.
know it has. So that's where we think it works.
I think that maybe it's because we're looking for this more, or is it because it's becoming more common? But it seems like we're seeing more and more younger patients that are needing these treatments. Do you notice that in your clinic, or is it just something that you're looking for it more, so you're going to find it more, or that sort of thing?
Well, I think the treatments are more common these days, so people realize
Hmm.
it and they read about it, and it's all over the internet and things like that. And as people find out about it, and they search out, specialists in the area. I mean, there are besides us, there are reproductive immunology people
Hmm.
around the country that people seek out, from all over the world because they're having trouble or the doctors don't, necessarily believe in these treatments. And so they're treating patients from all over the world sometimes. And we see them too. And, that's where this situation, yeah. I mean, maybe it's more common, but it's just more out there. More people
Hmm.
know about it. Let's put it that way. In the past, maybe people didn't discuss it as much, or IVF wasn't as common years ago, and now it's more out there and more accepted. So,
Hmm.
and now obviously not every embryo, even if it's genetically normal, is going to implant. And
Yes.
people figure, well, really good quality embryos, why aren't they implanting it? And that's where that whole situation arose. And that's where they were looking at, is it the endometrium? And they were looking at, ERA testing to try to see if it was related to some kind of endometrial progesterone factor. And that test really didn't show, definitively that was the problem. So we really don't have a perfect test for that either, and it's unfortunate because that would really be a big help in terms of where to go with all these things. So,
So
we just have
maybe
to
it's
have a good clinical assessment of the patient and what the situation might actually be.
It's true. And what about the role of inflammation in some of these patients that have multiple issues going on? Perhaps they have high cholesterol, they are in premature, ovarian failure, and then they also have recurrent pregnancy loss. Like how does inflammation affect the role of implantation and also the likelihood of the pregnancy actually being healthy?
Well, when I think of inflammation, obviously if it's something medically that we can, actually see in the patient, like their diabetes is way out of control or they have some obvious disease that causes a lot of inflammation, we got to get that disease managed. Obesity being a problem, where there's microinflammation going on in the body, in the adipose tissue and things like that. That's creating inflammation. So we got to get that improved and get the BMI down. That's why we always try to, you know, make sure we transfer somebody with a BMI around 35 or less to reduce the amount of inflammation that might cause implantation failure or, things like that. Because, the higher the degree of obesity, the less likely they're going to have implantation. So, medical diseases that are obvious need to be managed. But then there's microinflammation, things that you don't know about, which I always think is endometriosis,
Yes, very
silent
hidden.
endometriosis.
Metabolic
That
syndrome, maybe, or insulin resistance.
Yeah, that
Mhm.
too, like pre-diabetes. So, or endometriosis, which I think plenty of people have with implantation failure that they don't know about it
Mhm.
because they're not symptomatic. So that's
Yeah.
where we'll be looking for things like that with the immune system or looking with surgery or whatever it may be to try to detect that problem and try to treat it as much as we can. Because if
Mhm.
that's implicated in any of this, we've got to stop it.
No, there's definitely well, and as far as endometriosis, sometimes people don't know they have it for 10,
Right.
12 years,
That's
and
right.
they
It's
just
very, very
yeah.
common. I think it's more common than what they quote out there.
Yeah.
You
And
know,
and there's still
again,
not a
being
good test for that either, like, there should be
no,
a really I mean, I heard about a saliva test in Europe that was being used to detect endometriosis that from Spain, I think it was, and, I just don't see anything here that's, being you would think with all the new developments we have with, all these different treatments, that there should be an easier way to detect endometriosis by now, but
yeah,
you haven't
besides
heard of
surgery.
any.
I mean, there's
Mhm,
the receptiva biopsy, which I've used. I think that's a good test. And I think that gives us an idea that maybe they're lacking certain implantation proteins or things like that, or
mhm,
certain ones that are present that shouldn't be there. That might give us an idea that somebody's got something like that, and maybe it'll prompt us to do surgery on these people, which we don't do a lot of these days, but maybe in this case, or we give them 2 months of Lupron to try to get rid of it to reduce that inflammatory load because maybe that's
mhm.
what's causing it. But we don't have any definite answers in terms of that. Whether that's the best thing to do is to treat the inflammation. I mean, to treat the endometriosis as aggressively as we do.
Yeah.
Presumably, that's going to help a lot. We think it does.
Yeah, there's still, I think, a lot of debate. It seems like with every clinic, they have their own protocol as far as do we even look at the immune system or do we just keep going and do these treatments and not consider any type of like treatment for inflammation or autoimmune dysfunction. And we do see, and I'm sure you see patients too that come from different offices that go, wait, I want to have answers, give me some answers of what's going on in my body. So how helpful do you feel like the natural killer cell blood test is? when they get those lab results back, and what are you looking for in that test?
Well, that, again, like I've had people that don't have any elevations of those levels or their activity, but their cytokine levels are off the wall
Hmm. Okay.
and they have no symptoms. And then we start figuring, well, what's causing it? And we start looking for all kinds of maybe immunologic problems. Do they have silent some kind of lupus? Do they have some kind of autoimmune thing? Generally not. And I think that's mild endometriosis doing it. And in those cases, I've got actually two or three now that are going to end up doing surgery to see if we can determine if it's there. And, we have to have the proper surgeons looking at them to see that the experienced ones that could find it and treat it and hopefully excise as much as we can. And that hopefully will reduce the inflammatory load for them so that they can implant these embryos, because I've had one that even failed IVIG, and that's why we're doing surgery on them. So,
Okay.
there's some really tough cases out there that we don't always get the answers for, but we
Yeah.
look.
Yeah. Well, that's the important thing, is the curiosity to make sure that, we can try our best to help patients that are
Right.
experiencing this.
Because, to
Yeah.
me, doing the same thing over and over again is a
It's insanity.
definition of being ridiculous.
Ridiculous and insane. Yes. Yeah, I agree. And I think this is so important. And if anybody is listening to this, we are doing these chats for National Fertility Awareness Week that is coming up the third week of April every year. We expand these conversations. We like to go in depth. And if you have questions regarding your treatment, or you want to know more about reproductive acupuncture or IVF with Dr. Gelman, or any other questions that might come to mind, please get in touch with us. We do have a lot of information, and hopefully we can get you to the right place that you need to be, or offer a consultation to help you out. But you can join us on Instagram also, and we are going to be putting these conversations on YouTube. So we will link those in our Instagram pages and new TikTok pages as we get further into it. So we thank Dr. Gelman for joining us. My name
Thank
is
you.
Sarah Duro, and he's Dr. Gelman. We'll see you back for the next episode, and we look forward to more conversations.